Good afternoon, everyone. I think we can go ahead and get started. I want to welcome you to the June edition of Pain Research Working Group. I am going to go ahead and introduce our speaker for today. Today, our speaker is Dr. Elizabeth Goldsmith. She is a core investigator at the Center for Care Delivery and Outcomes Research and a staff physician in general internal medicine at the Minneapolis VA Healthcare System, an assistant professor in the Department of Medicine, University of Minnesota Medical School. Dr. Elizabeth Goldsmith is a general internist and social behavior epidemiologist interested in structural and psychosocial factors driving development, diagnosis, and management of health conditions, particularly chronic pain. Her current research investigates use of non-drug therapies for chronic musculoskeletal pain and evaluates potential biases in electronic medical record-based research. She provides primary care to veterans at the Minneapolis Women's Comprehensive Care Clinic and is a physician on the National Veterans Affairs Transgender and Gender Diverse e-Consult team. Today, Dr. Goldsmith will be discussing implementation of evidence-based psychotherapies for chronic pain, a systematic review. I want to thank Dr. Goldsmith for joining us today. I think we may have a little bit of a smaller group today because Dr. Goldsmith presented the findings of this ESP report just last week in an HSR&D cyber seminar. So we're glad that you had the opportunity to come today and get the word out to additional folks. And I'm thanking you for coming today. And I'm going to go ahead and turn things over to you now, Dr. Goldsmith.
Thank you, Dr. Heapy. Appreciate it. And thanks to everyone for coming today. I apologize for the repeat performance for those of you who did attend last week at the HSR&D Cyber Seminar. But I'm hoping we can have a robust discussion at the end because I know there's a lot of relevant expertise in this virtual room. So today we'll be discussing some findings from our recent systematic review entitled Implementation of Psychotherapies and Mindfulness-Based Stress Reduction for Chronic Pain and Chronic Mental Health Conditions. And the full report is available in the HSR&D Evidence Synthesis Program, or ESP, website. And our co-authors are listed here. The senior author of the report is Dr. Dwan Porter, who is also a co-director of our Evidence Synthesis Program Coordinating Center in Minneapolis. And she will be joining us today to help moderate chat and weigh in on questions, which we appreciate. And as always, no statement in this presentation should be construed as an official position of the Department of Veterans Affairs or the United States government's findings and conclusions in this report and in this presentation are those of the authors. And we have no financial disclosures to make. We'd like to acknowledge the VA HSR&D Pain Opioid Corps for hosting us today and for requesting this topic through the Evidence Synthesis Program in the VA, and also to thank the expert members of our TEP, or Technical Expert Panel, who advised the development of the review from start to dissemination. Our hopes, our hopes are that at the end of this presentation, folks will be able to recognize the Consolidated Framework for Implementation Research, or CFIR, to summarize existing evidence on barriers and facilitators of evidence-based psychotherapy use for treatment of chronic pain, and also to highlight a few results from evaluations of implementation strategies for psychotherapies for chronic pain and chronic mental health conditions, and explain some implications for research policy and practice. And I'm hoping attendees can weigh in on their thoughts, especially on this fourth objective. Don't need to preach to this choir that chronic pain is bad and prevalent. We'll just note, as many attending know, that chronic pain is prevalent among U.S. military veterans to a greater degree than among civilians, and is associated with higher levels of psychological distress, as well as higher prevalence of mental health conditions, including PTSD, depression, anxiety, and insomnia. And this group also knows well that biopsychosocial assessment, followed by optimization and implementation of non-opioid and non-pharmacologic therapies for chronic pain is recommended first-line treatment. This includes psychological therapies that have evidence of effectiveness for chronic pain. And so this is the portion of our discussion where I will attempt very brief introductions that will not do justice to the complexities of some psychotherapies, but 3 psychotherapies in particular have strong evidence for effectiveness in chronic pain. And they are cognitive behavioral therapy, mindfulness and mindfulness-based stress reduction, and acceptance and commitment therapy. So some very brief introductions, and hoping folks with expertise can weigh in the discussion on relevant content. For those of us who were not familiar with these practices, CBT, cognitive behavioral therapy, is often credited to a United States psychiatrist, Aaron Beck, who started to develop this program in the 1960s for depression, and quickly many colleagues became involved and adapted this therapy to treat many other conditions, including anxiety, substance use, eating disorders, and more. CBT has roots in behavioral and cognitive psychology approaches that were developed decades earlier, and arguably also in philosophies developed millennia earlier, such as Stoicism. And some key principles of CBT include the idea that problems relate to unhelpful ways of thinking and behaving, and that those ways of thinking and behaving can be changed and are better coped with through an active process of identifying and reevaluating unhelpful thoughts and behaviors to engage in a process of change. And some proposed mechanisms by which CBT helps with chronic pain, as evidence shows that it can, include decreased catastrophizing and increased self-efficacy for pain management moving forward. Mindfulness-based stress reduction, on the other hand, is related to mindfulness and meditation practices that have evolved across cultures and time. Of note, MBSR, mindfulness-based stress reduction, is a structured format of meditation and mindfulness practice that was adapted in the 70s and 80s by John Kabat-Zinn. He was originally a molecular biologist at the Massachusetts Institute of Technology, who developed an interest in meditation and stress reduction after studying with Zen practitioners, and I believe he studied with Thich Nhat Hanh as well. He started a stress reduction clinic at UMass Medical School in 1979. He developed components of MBSR there, and his work was part of a larger movement that brought the US healthcare system to awareness of and interest in the benefits of meditation and mindfulness, and made it part of popular culture. There's a plethora of cheerfully colored mindfulness quotes available on the internet, and this is one of them. And MBSR, again, in that structured format, has been shown to be effective for chronic pain. Some proposed mechanisms there include increased mindfulness, leading to increased pain acceptance and quality of life. And then finally, acceptance and commitment therapy, or ACT. This therapy is credited to United States psychologist Stephen Hayes, who developed this work in the 1980s and 1990s on with colleagues. It is part of the larger family of behavioral and cognitive therapies. And my understanding is that, in principle, the core unit of analysis with an ACT is an action, which is then understood in reference to its context. So the point being that thoughts relate to specific emotions and behavioral events, but exist in situational contexts that give rise to both the thoughts and their relationships to subsequent emotions and actions. And that contextual nature of those relationships between thoughts, emotions, and actions is a clinical focus of ACT that some argue is left out of some cognitive models. Again, happy to hear more from psychologists and therapists as we move to discussion later. This image is the hexaflex, which not all psychologists will agree is definitive for ACT, but it lends itself well to a brief presentation. It shows that a key principle within ACT is psychological flexibility, which is thought to be achieved in part through these 6 constructs that are displayed. Looking at these, we can notice some shared elements in terms of principles between ACT, CBT, and MBSR. So the idea of self as context, noticing thoughts, of cognitive diffusion, observing your thoughts without being ruled by them, are components of CBT. And then these constructs, as well as being present in the here and now and being willing to experience difficult thoughts, are components of mindfulness and of MBSR. So there are shared psychological principles. There are differences in how these principles are operationalized, what is prioritized for clinical focus, how the therapy is conducted, the roles of the therapist or facilitator and the patient or group, and many other components that colleagues in mental health know well. But these 3 therapies, CBT, MBSR, and ACT, in various forms, are evidence-based psychotherapies, or EBPs, for chronic pain. And in order to increase use of these therapies accordingly, VHA has developed national initiatives, including an implementation program of CBT for chronic pain in 2013. But there is still limited uptake of these psychotherapies for chronic pain treatment. So folks are interested in how we can increase use of these effective therapies. So our systematic review asked some relevant key questions to try to inform next steps in increasing uptake. For CBT, MBSR, and ACT, what are patient, provider, and system level barriers and facilitators for treatment uptake for chronic pain? And most of the presentation today will focus on those results. And then I'll illustrate some highlights from an additional key question we addressed in the review. What is the effect of implementation strategies to increase uptake for chronic pain and chronic mental health conditions, with hope that we could extrapolate from some of those conclusions to chronic pain? And briefly on our methods. So our search strategy included mesh and free text terms for the evidence-based psychotherapies, chronic pain, veterans, and barriers and facilitators. And we explored the following databases, as well as expert suggestions and referrals. Our selection criteria included adults with chronic pain or chronic mental health conditions, an eligible EBP, CBT, MBSR, or ACT. Outcomes need to be related to implementation or to barriers and facilitators to uptake and use. We explored work within a small set of non-United States countries with comparable economic, cultural, and public health contexts, and health systems with qualities comparable to VHA. So although implementation-related evidence from excluded countries might have been less applicable to US health systems, it's possible it may have provided some relevant information. We did focus on these countries in part also because we had to require English language reviews due to our available resources within our team. Our exclusion criteria included acute care settings, pain due to active medical treatments such as radiation. We also excluded forms of EBPs that included movements or were related to movement therapies, where movement was thought to be one of the primary causal factors in effect. We also excluded hospice or end-of-life care and article forms such as reviews and editorials. Two reviewers independently rated quality separately for quantitative and qualitative studies based on established criteria. And two reviewers abstracted results related to participant characteristics and settings, data sources and analytic methods, and coded results relevant to qualitative studies. We did this by assessing, we'll focus here on barriers and facilitators, assessing content using the categories of the Consolidated Framework for Implementation Research, or CFIR, and conducting best fit framework synthesis based on that framework. So what are these two bolded sets of terms? For those of us to whom this is somewhat new, let's take a step back and discuss implementation and framework synthesis as an approach to a systematic review. So it is frequently stated, many of us have heard this number, it takes an average of 17 years for an intervention that's well supported by research evidence to become a standard part of clinical practice. And that number comes from studies of a range of interventions, including pharmaceutical and technological innovations, estimating an average time lag of 17 years, measuring different points of the process of translation from research evidence establishment to incorporation in clinical practice. But that convergence around an average time lag does hide the complexities that are the real stories of how the interventions meet clinical settings and how change happens within healthcare. And so implementation is the study, implementation science is the study of how that process happens. And implementation is an effort to make that translation happen. So why does it take so long? How can we improve uptake and how can we organize our efforts to do that? So I'll attempt a brief intro both to the Consolidated Framework for Implementation Research as a way of thinking about this. So when we consider an intervention, particularly a behavioral intervention, any such intervention has core components. These are elements of the intervention that are essential to its effects and that can't and shouldn't be changed as we roll out this intervention in different settings. And there will also be some elements of the intervention that are adaptable, that are dependent on context, that can and often should be changed in order to increase uptake of that intervention. And yes, knowing that difference is the hard part, especially sometimes for behavior change interventions or any intervention that involves communication between people, which most of our work does. The adaptable periphery can include things like design and packaging of components of the intervention or communication materials around it. But it can be more complicated. It can relate to the format, it can relate to the dosing or number of sessions, it can relate to content within sessions, and it's the work of content experts, to help others understand what are core components and what are adaptable components within an effective intervention. And then that intervention exists within a context. within a healthcare system. There will be individuals who are involved in implementing the intervention, either as providers or as surrounding staff. They will have certain knowledge and beliefs about the intervention or the conditions at hand, about their own self-efficacy in implementing and various other characteristics. And those individuals work within a setting, such as a clinic, which will have its own structural characteristics, its own culture, and relevant norms, values, and assumptions that may relate to how the intervention exists in that setting. That clinic then exists within an outer setting, within, for example, a health system, where there will be certain needs and resources of patients that may or may not be well understood by different elements of that system. There will be external policy and incentive components. And all of this and all of us exist in time. So there will be cycles where over a process over time, wherein the intervention is used, information is exchanged, feedback is given, and the process and the elements that are adaptable are adapted or not. So these elements, in the characteristics of the intervention itself, the individuals involved, the inner setting in which those individuals in the intervention sit, the outer setting, and then the process of change over time are all elements of how we can itemize this implementation process, the process of change. And if you're thinking this looks like quality improvement or QI, and that a health system that engages in these process cycles regularly looks like a learning health system or LHS, I would say that's true. I came to health research from nonprofit work. I learned about QI, implementation, LHS. I thought these look like monitoring and evaluation, or M&E, work that we do with an intervention over time in context with community. These are all about how we outline processes of change within a system made of complex and moving parts, including people, to start doing and keep doing a new and better thing. And there are many models of how this change may happen within a system that have overlapping constructs and sometimes mismatched definitions, because as humans and research will do, we try to come up with process and explanatory models, sometimes at the same time, and we may define things differently. So CFIR, the Consolidated Framework for Implementation Research, is a typology that was developed in order to provide an organizational tool, a list of constructs that have been shown through published evidence to be relevant to treatment uptake, so that one can categorize these concepts in practice and help connect evidence, like the kind we tried to synthesize in this report, to targets for future strategies to improve uptake of an intervention or implementation strategies. And you can see within each domain, like for example, characteristics of an intervention, there are subdomains like adaptability, the degree to which an intervention can be adapted to meet local needs, the ability to test the intervention on a small scale in the organization, design quality, perceived excellence in how it is bundled, presented, and assembled, and so on. Several subdomains within intervention characteristics that have been shown to be relevant. And then, for example, within the outer setting, that setting of, for example, a health system, the extent to which patient needs and barriers and facilitators are known and prioritized by the organization, external policies and incentives that may be relevant. So CFIR as a whole is a list, a typology of these different constructs that have shown to be relevant within these different subdomains. Or within these domains, rather. So we took this typology, this framework, we used it as a system to try to organize the findings relevant to barriers, facilitators, and implementation within the articles we reviewed. And that was the basis of our best fit framework synthesis work. So what does that mean? So any framework will fit the data to some extent. We may also find content within the data that doesn't fit perfectly within existing themes. And so a recognized approach to handling that scenario and representing the data well in synthesis is to use the framework as the foundation and develop additional constructs to add to that framework to best represent your data. So we defined our review question, we identified relevant research studies, and we identified CFIR as a best fit framework to organize the constructs we would find. Then we extracted data, assessed the quality, coded the evidence into the framework, and then created new themes through secondary thematic analysis and any evidence that didn't fit our a priori CFIR framework. And then we described those constructs that we developed, which I will here in a minute. So best fit framework synthesis was a portion of our method of combining data for this review. And so which data did we combine? So as is often the case in a systematic review, a huge quantity of citations met our initial criteria, those that I described earlier before delving into implementation. We removed duplicates. We screened over 7,000 abstracts. and then reviewed over 500 full-text articles. And a reminder that we're talking here about articles included that contained outcomes related to barriers, facilitators, and implementation evaluation for these 3 evidence-based therapies, CBT, MBSR, and ACT, for chronic pain. So most of the full-text articles that we reviewed were ineligible either because they did not include those implementation-relevant outcomes, or because the intervention turned out not to be one of the 3 evidence-based psychotherapies that were of interest. And then some were excluded for other reasons as well: study design, population not being relevant, or the setting not being relevant. And then of those 20 articles that we found, 1 addressed both CBT and MBSR, and 1 addressed both ACT and CBT. So that's why the total comes out to 22, if you're keep doing the math in your mind, and looking at some of their characteristics. So we will note that the CBT articles that we included were related to studies conducted mostly within randomized controlled trials. And the ACT articles, which again related to barriers, facilitators, and implementation outcomes, were all within randomized controlled trials, while MBSR mostly were not. And studies of CBT took place mostly within the US, over half were conducted within the VA. And MBSR were all within the United States, mostly non-VA. And fewer findings in general for ACT. Some more general characteristics of these articles. So MBSR and ACT, in terms of therapy format, were all conducted in groups and were all conducted in person within included studies. Whereas CBT was conducted more often in individual settings, and 3 of them were telehealth in format. And 2 of those were by phone. So this is a good time to note that we were reviewing articles published through March of 2021. So we did not capture the sea change to telehealth for the most part that has occurred since COVID, which will be relevant to some of the implications of synthesis and is relevant to need for future work. With respect to analysis methods, proportionally more articles assessing CBT were quantitative, and proportionally more articles assessing MBSR and ACT or ACT were qualitative or mixed methods in design. And this will relate to the types of themes that they explored. So here again is our consolidated framework that we used as a best fit typology for the constructs that we identified in these articles. And I'll start graying out the domains and subdomains for which we did not find implementation evidence. So both inner setting, functional elements within, say, a clinic, or process elements were not identified. Those 2 subdomains were not identified within articles that we included. And this is not surprising when we consider that most studies were conducted within effectiveness RCTs that were not conducted within clinical settings. So in terms of their organization, were not pragmatically designed to be incorporated into existing clinics and clinical processes. So within effectiveness RCTs that don't have that as part of their structure, often the infrastructure of the trial replaces the inner setting and the process to some extent of a clinic. And so understandably, we did not find results within those domains. And we also were needed to develop, here in blue, some additional subdomains to represent elements that were not originally within CFER, but were relevant barriers and facilitators within identified studies. That included for MBSR and ACT, patient reporting of group dynamics and how that served as a barrier or facilitator to their participation, or for CBT, patient and therapist dynamics. And then within outer setting, patient knowledge and beliefs about pain or about the intervention, and other patient attributes. So you can see that the themes that we needed to develop in best fit framework synthesis were needed because of the greater quantity of patient level data and representation of patient views and experiences that we found within existing studies. And again, because most studies were of patients and within effectiveness RCTs, we had less information about some elements of intervention characteristics in outer setting. So those subdomains are grayed out. And then within characteristics of individuals that are involved as stakeholders or clinicians or providers or clinic staff related to an intervention, we didn't find much evidence There was one article that offered some GPs or general practitioners knowledge and beliefs about CBT. So here is the list of domains and subdomains within CIFAR within which we found data. And again, the blue subdomains here are those we developed in the process of best fit framework synthesis. And a little more on those subdomains developed. So patient knowledge and beliefs, as we developed the theme, related to individuals' attitudes toward and value placed on the intervention, familiarity with facts, truths, and principles related to the intervention. And we broke this down further into knowledge and beliefs as expressed about people's pain, or knowledge and beliefs they expressed about principles of the therapy. And we can see that patient knowledge and beliefs were often assessed qualitatively. See this blue circle here, attempting to do a visual representation of the study design types, or through mixed method studies, with the exception particularly of some quantitative analyses related to the pain stages of change questionnaire for CBT for chronic pain, which did allow quantitative assessment of therapy-related knowledge and beliefs and how that related to attendance. And then another subdomain we developed, other patient attributes, a broad construct including personal patient traits, which also includes demographics and patient characteristics that didn't fit under other CIFAR subdomains. And we can see that particularly for CBT, these were largely assessed quantitatively, often in the form of a regression wherein attendance of a number of sessions of CBT was the dependent variable, and then independent variables were things like diagnoses, types of diagnosis related to pain, or whether someone had had opioid or non-opioid therapy before, or specific demographics, again, as a quantitative predictor. So age, race, sex, or gender, not always defined, and we'll get into that a little bit more. And then within intervention characteristics, new CIFAR subdomains included group dynamics, which you can see was relevant only for ACT and MBSR because there were no group CBT approaches in included studies, and patient-therapist dynamics, which is relevant only to CBT in our assessments. And then I'll attempt to summarize with a little more depth some of the findings related to barriers and facilitators for uptake, again within CIFAR subdomains. So for the 13 articles that address cognitive behavioral therapy in some way, we found related to intervention characteristics, 1 point related to evidence strength and quality. So GPs in the UK were interested in culturally relevant CBT for South Asian patients. Within design, quality, and packaging, some patients with chronic pain who used CBT for chronic pain found that self-management materials helped them understand CBT principles, prompted use of skills, but also that these could be repetitive and sometimes unclear with dispiriting case studies. There was one cost-effective analysis of CBT and MBSR within a trial in Washington in the US. And this study found that CBT was cost-effective for improving quality of life and not significantly different from usual care and healthcare utilization or productivity losses. And then within the domain of patient-therapist dynamics, patients appreciated empathic, consistent, and reliable care from therapists. For the 5 articles assessing MBSR within the subdomain of design, quality, and packaging, some MBSR participants found that recordings and handouts helped them adapt their routine for home practice. That when in person, they wanted the sessions to be held in quiet, uncrowded, and consistent spaces. That same cost-effective analysis, that same analysis found that MBSR was cost-effective for improving quality of life and not significantly different from usual care in terms of healthcare utilization or productivity losses. And within the subdomain of group dynamics, patients appreciated social support, talking with people with similar experiences, but also found that structure and control by the facilitator was important to keep the discussion on track. And within ACT, fewer findings related to intervention characteristics. Patients did report that they appreciated the non-judgmental atmosphere within group therapy, as well as support from other participants and hearing different perspectives about managing pain. More findings within the domain of the CIFAR domain of outer setting. So for CBT, within patient needs and resources, there were a couple of articles citing a need for culturally specific care and the importance that therapy being conducted in patients' primary language. Some participants in telephone CBT found that it increased accessibility and it eliminated time and geographical barriers. But some participants also did find that pacing skills within CBT were difficult to use at home outside of therapy sessions. Within patient knowledge and beliefs, some participants found that CBT increased understanding of pain triggers, but some participants did note difficulty accepting the idea of a mental health treatment for what they perceived as a physical condition. And within other articles, quantitatively assessing session attendance, treatment acceptability, as reported by patients, was a predictor, not surprisingly, of attendance. And adherence to therapy was related to stages of change. Other patient attributes assessed included pain interference, catastrophizing, and opioid use. These at baseline were associated with lower attendance of CBT in some studies, but not all. So the signal was mixed. And patient demographics overall were generally not related to attendance of CBT. For MBSR, within patient needs and resources, some found that time commitment, responsibilities, and physical pain during seated meditations were obstacles to participating, again, in group sessions. And some folks with chronic pain did note that online and shorter sessions might eliminate some barriers for them to participation. Within patient knowledge and beliefs, some participants did note a desire for a more focus on how to control pain specifically, rather than general mindfulness practice. And more open focus on their concern about meditation increasing pain. And some had a desire for more movement incorporated into the practice. For MBSR, as well as for CBT, baseline pain interference at a higher level was associated with less frequent attendance of MBSR in a few studies. But patient demographics overall were generally not related to attendance. And interesting, within one qualitative study, some providers who would have been involved in referral did note some concern that patients' religion or spirituality might form a barrier to acceptance of MBSR. Yet patients themselves, when this topic was brought up, did not see religion or spirituality as a barrier to participation in MBSR and noted they didn't see it as relevant. Within ACT, patient needs and resources, some participants did find sessions cognitively, emotionally, and physically demanding. Some participants did fear causing damage. And those who had a focus on a specific pain diagnosis or cure as likely to have a more positive effect on their chronic pain long term, people who had that view overall had less engagement in ACT. Some participants, though, did find identifying psychological factors in pain helpful, while others found the content not relevant to pain, and overall acceptance and mindfulness were controversial concepts within patients. Within the population of patients within the studies that reported patient views. And within ACT, within quantitative assessments, patients who did not attend sessions did not differ from those who did on pain location, intensity, or distress. And as with MBSR and CBT, patient demographics were generally not quantitatively related to attendance. So in summary, in terms of barriers and facilitators of CBT, MBSR, and ACT for chronic pain. Within the studies that we identified, the barriers and facilitators focused on patient-level findings. So we did adapt CFIR through best fit framework synthesis to expand the patient-centered subdomains to include the data that we found. Some shared facilitators across these three therapies were a good match between patient knowledge and beliefs about pain and EBP principles and positive group or patient-therapist dynamics, while some shared barriers were variable patient buy-in to therapy rationale and competing responsibilities for patients. One article showed that CBT and MBSR for chronic pain were cost-effective for improving quality of life. Overall, patient demographics were not related to EBP attendance and included studies. A reminder that these elements were quantitatively assessed with using demographic variables such as race, ethnicity, sex, and gender, which were often not clearly defined. And no studies assessed the role of cultural and social factors in patients' views or experiences of EBPs. So it's difficult to know what the inference might be about the cultural and social implications of these quantitative demographic findings. And the EBPs, as assessed, had widely variable formats in terms of elements of sessions, in terms of the length and number and spacing of sessions. And sometimes this flexibility is a key part of these therapies by design, as many psychologists know. We also know that adaptability can be key to uptake of the core elements of an intervention. But especially for chronic pain, from a research, clinical practice perspective, it can make it challenging to determine what's core and what's adaptable. All articles assessing MBSR or ACT involved in-person groups, while most articles assessing CBT involved individual therapy, with a minority telehealth. Again, these articles assessed through March of 2021. And all ACT and most CBT studies were within RCTs that did not use existing clinical infrastructure, which does limit assessment of factors related to intersetting process and intervention adaptation. Looking at time, briefly, I'll give some findings related to implementation evaluations. So hearkening back to our initial key questions, we did also look at implementation evaluations of implementation strategies for CBT, ACT, and MBSR, both for chronic pain and chronic mental health conditions, with hope that some of the implementation information that we might find for implementation of these three therapies for other conditions might be relevant to extrapolate for chronic pain for future implementation. We identified 10 eligible studies, which produced 12 articles that we included, of strategies to implement CBT or ACT. We found no implementation evaluations for MBSR. One of the CBT implementation studies was of CBT for chronic pain. The rest of the CBT and ACT studies were related to mental health conditions. All were conducted in large integrated healthcare systems by our design. 8 of these were conducted within VHA and 4 were national VHA initiatives. And we categorized the types of strategies, again, using a framework. So I'll do brief introductions to a couple more frameworks relevant to implementation. So expert recommendations for implementation change, or ERIC strategies, which more detail can be found in the cited reference, include training and education. So training and education of providers, clinical staff, or other stakeholders in content and knowledge relevant to the intervention. We found 11 articles that implemented this implementation strategy. Audit and feedback involves collecting and summarizing clinical performance data and giving that to clinicians and administrators to monitor, evaluate, and modify provider behavior. We found 10 articles involving this implementation strategy. And then facilitation, interactive problem solving and support. People involved in the facilitation will engage with stakeholders to within a system to help the implementation process along, and they may be internal to that system or they may be external to that clinical setting implementing change. And we found 9 articles evaluating this implementation strategy. And then of the strategies that we found, we then categorized them in terms of content areas or approaches, or in terms of implementation outcomes using the RE-AIM framework: reach, effectiveness, adoption, implementation, and maintenance. So I'll give very brief findings while defining these implementation concepts. So reach refers to the number, proportion, and representativeness of individuals who are willing to participate in the intervention, and reasons why or why not. And we found few results and none from VHA studies related to reach, to information on how the targeted population was or wasn't reached with the intervention. Effectiveness refers to the impact of the intervention on key outcomes, symptoms, quality of life, and so on. And as expected for these therapies, there were moderate to large improvements in symptoms and function where these evidence-based psychotherapies were effectively implemented. Adoption refers to the number, proportion, and representativeness of settings and providers who are willing to use the intervention. And we found that trained providers did use the therapies as planned during the course of the intervention, but we found very little information on the representativeness of those providers within settings. Implementation in the context of RE-AIM refers to provider fidelity to core components of the intervention and consistency of delivery. And included studies found that trained providers were competent and maintained fidelity to core components, but had ongoing barriers to use, both related to provider time availability and patient participation due to some patient-level barriers, as previously described for chronic pain. And then finally, maintenance refers at the setting level to the extent to which an intervention becomes part of practice or institutionalized, if some people like that word. part of routine organizational practices. And we found limited evidence in included studies for maintenance. Some providers were using the implemented therapies 3 to 12 months after the training ended. So some recommendations for future research based on these findings. There's a need to examine provider and system level barriers and facilitators for CBT, MBSR, and ACT for chronic pain. Most information we found was at patient level, which is important and is one part of the complex story of an intervention in clinical context. There's a need to do this examination using comprehensive frameworks that allow connection of findings to future strategies for implementation and examining these elements in clinical practice settings. There's a need to evaluate patient-level factors that contribute to heterogeneity of treatment effects and treatment uptake for EBPs for chronic pain to identify targets for future effectiveness and implementation work. And there's a need to evaluate patient-level sociocultural and demographic factors, including sex, gender, race, and ethnicity, accurately and with clear analytic purpose, recognizing that demographic indicators are very limited proxies for sociocultural experience. There's a need to evaluate implementation of MBSR, especially in large integrated healthcare systems, given the lack of information that we found in existing literature. And some recommendations for policy and practice. There's a need to support evaluation of provider and system level factors and implementation readiness. This can include local needs assessments that involve matching of strategies and resources. There's a need to evaluate outcomes for alternative evidence-based psychotherapy delivery formats, individual versus group therapy, brief versus longer treatment duration for chronic pain, and where appropriate, to support increased options for session formats. And a strong need to evaluate outcomes for telehealth versus in-person EBP delivery. Again, where appropriate, support increased options for both formats and scheduling flexibility. And finally, to develop and disseminate tailored patient-facing resources to increase awareness and buy-in. So I'm coming to a close of prepared remarks. I'm looking forward to discussion and thoughts from all of you who have stuck it out for this presentation about what you think the next steps might be and any questions that you may have related to our work. What we've tried to do in this report is summarize what evidence exists about barriers, facilitators, and implementation strategies for these psychotherapies for chronic pain and for some chronic mental health conditions. Our hope is that this can inform future work for experts in these therapies who can help distinguish these core components from the adaptable periphery and find ways to increase uptake and spread of these therapies for veterans who can benefit. So here, some references are included in the slides, and our full report, again, is available along with the citations of the included articles on the Evidence Synthesis Program website within HSR&D. So with that, I will thank you for your time and open it up for discussion. And I'll see if I can take a look at the chat. And I think Dr. Dwan Porter is with us as well. So I see we have a small crew, and I thank you for making the time today. And I'm wondering if anyone would like to weigh in based on their experience and with some of the content that was discussed today.
Maybe I can start out. This is Alicia. So the Pain Opioid Core kind of nominated this topic because we were interested in understanding if, looking across studies and trials, if we could synthesize information, especially by focusing on a single health system and looking at these evidence-based psychotherapies, that would help us understand how to increase uptake for these interventions that are really, first-line non-drug treatments for chronic pain. And unfortunately, there's not a lot to synthesize. And I guess that really tells us we have a lot of work to do. That was, one of the biggest takeaways, especially around implementation strategies. There really didn't seem to be a lot of those. And a lot of them were really focused on the provider, at least from my standpoint, educating the provider, auditing feedback to the provider to support their referral, which I think is important. But it seems also that we're missing an opportunity to develop demand or interest from patients. Kind of this push-pull concept that Sarah Krein introduced me to, of developing that pull from the patients, and we don't really seem to have focused much on that side of things. We kind of wait for the provider. We work through the provider, and that seems fairly inefficient to me. And that may be a potential area for future work.
Thank you for that, Dr. Heapy. Do any participants want to weigh in on that?
I think the only thing I would add to that is that I kind of view this as maybe an earlier stage, right? Because most of the implementation are actually VA programs rolling this out. And I kind of feel like the starting place was that we should have the ability to provide these therapies, which I don't think we would disagree with, right? That first you need to train people, they need to be able to do these things well. And that was the focus. And I think I completely agree that now, if we have the ability to provide this, which I don't know that the studies are saying, like this idea of reach for us, we were struck a little bit that we didn't know, like we don't know what's availability and uptake across VA clinics, for example. But even thinking that the access is there, which we're not sure about, then focusing on patient, how do we really provide materials, or what are the settings where we provide information? How do we get that demand up? I think is correct. That does appear to be the next step. The VA seems pretty good at rolling these out based on the reports for all the psychotherapies, not just for chronic pain, but whether people are actually using it, I think is perhaps the more important question at the current point.
Folks who were at the end of the cyber seminar last week might have heard some representatives from the Pain Opioid Core Veteran Engagement Panel weighing in, and they made many excellent remarks. You should watch the recording, the last 15 minutes to hear what they have to say. They shared some thoughts about just lack of exposure to the idea that these specific therapies existed, that they could be effective for chronic pain. Just a representation that they hadn't heard of these or heard about them. And it, made me think about how much we know about within different health systems, how referral processes happen. So I'm speaking a little beyond my knowledge. I'd love to hear people's input. It feels like there's kind of two populations within VA. There are folks who are already engaged with mental health care and folks who are not. And there are people with chronic pain who are in both of those categories. And they would have a very different experience in terms of exposure to the concept of having CBT or ACT or MBSR for chronic pain. One group might hear about it from a mental health provider with whom they already have a connection for other reasons. And one group would hear about it through primary care, if at all. And so I would venture to guess, we don't know because we didn't find articles in the evidence, but I would venture to guess that the awareness of primary care providers of these types of therapies and their effectiveness for chronic pain and how to introduce them to folks in a way that supports demand is probably low. So I wonder if that's also an area for potential implementation intervention, particularly for folks with chronic pain who aren't already engaged with mental health. But I'm interested in everyone's thoughts on that as well.
Hi, this is Letitia Travellini. I am currently doing a career development award looking at CBT for chronic pain in veterans with serious mental illness. So a group that has been pretty well involved with mental health care, and even, as I did some preliminary interviews leading up to my CDA, and as I'm doing some qualitative interviews as part of my CDA, it's kind of exactly like you mentioned. This is a group of veterans that have been exposed to CBT and know those CBT skills fairly well, but had no idea that CBT-CP even existed prior to this study. And a lot of them so far have been saying, like, it's great because it's taking a lot of the skills that they have already learned in PRRCs or individual therapy and just applying it in a different way and learning how to kind of use those skills a little differently to manage the pain. So I think that's kind of one avenue of thinking about, there is, a lot of overlap and comorbidities with mental health conditions and pain that, there might be more potential to either recruit or get CBT, CP, and other chronic pain psychotherapies, like either, I don't want to say like embedded in mental health care centers, but, thinking about the folks that already have that exposure and then how to kind of convert it into or increase that awareness that, hey, these same things you're doing to manage depression or anxiety can also be applied to manage pain. And I know clinically, with our CBT groups, we've been getting a lot of referrals from our trauma program. And those are the individuals too that I feel like, when we follow up to get them enrolled in groups, are much more interested because, again, they have kind of that CBT background or experience already and can learn how to apply those skills to manage pain as well.
Oh, that's great. Thank you so much for sharing your work, and congratulations on your CDA. Thanks for those contributions. Do you have a sense, within, I'm very excited to look up what you're working on and learn more. Do you have a sense of among mental health providers, what awareness there is or what strategies there might be for communicating with folks with pain around this? Or is it just widely varied, or is that not really a focus of your work?
It's variable. So I did a pilot qualitative project, primarily looking at veterans with bipolar disorder and providers that treat veterans with bipolar disorder. And, in those interviews, the providers, have a lot of CBT, mindfulness, and sometimes ACT experience, but sometimes don't feel comfortable, don't realize they have the skills or the knowledge to kind of apply them to manage chronic pain. So it's kind of this disconnect where it's like they do have the skills, but just never really thought about or had that additional training of how to then kind of focus on how to manage chronic pain, similarly to how they might be managing mental health concerns. So that was from, a very small sample. I think there were in 15 total providers, there were 8 or 9 that were mental health providers. So substantial from that sample, but still relatively small, that it is kind of this disconnect with providers too, where it's like you have the skills, but don't really realize it.
Mm.
Or even realize, like, how do you then talk to your clients in a way that, these same skills that we're using to help with the anxiety can also be applied to manage chronic pain, and getting that buy-in from the veterans to see pain not just as a medical problem, because that's the issue too. And I know that was brought up where it's like, well, my anxiety is a mental health problem, my pain is a physical problem. So my primary care doc treats my pain and my therapist treats my anxiety. And I'm sorry, my camera's not working, but I'm gesturing a lot, so I apologize.
That's awesome.
Gesturing for nothing. But.
Your gestures come out in the tone. That's great. Oh, thank you for sharing that. That's really, really awesome work. So I'm mindful of the time. I know it's 12:55. Very happy to continue to discuss with anyone who wishes to share their thoughts.
I just want to pick up on what Dr. Travellini was mentioning. I think we do have a messaging problem, right? So I think you mentioned from some of the studies, patients don't see some of these treatments as being aligned with their beliefs about pain. So we have that messaging issue. We have kind of the message, the entire system is, of course, a biomedically based system. That's how it runs. And so the whole messaging of the system is kind of organized around that. And so pain, especially psychological treatments for pain, kind of are this weird, but if this first thing doesn't work, maybe you should try the second thing. Or I think it's maybe not always clear especially to primary care providers, when it's indicated that they refer a patient for this type of treatment. And we have the stepped care model for pain, but it's not clear exactly when does that referral to the next step, when should it happen, under what circumstances, for what patients. So I do think it's almost like we need to be thinking more of like a population-based education effort. When you think about how we do it right now, it's highly inefficient to think about individual providers based on their interest or the time that they have, educate themselves about these treatments, and then patient by patient, offer this information, as opposed to doing something that is more broad-based in messaging. Seems like it would be more efficient, but of course, even though what we're doing is not totally working, it seems like a lot of money, sometimes an effort to undertake a big education campaign like that. But it seems like those are the kinds of things that might be necessary in a system in the VA where we really have done a lot already to implement these treatments. We're really a lot more ahead of many other places, and still there are barriers.
Thank you, Dr. Heapy. Would you consider that to be, in the ideal world, involving different types of clinical staff and stakeholders in that education campaign, as well as veteran facing, or what are your thoughts about the structure of that?
If I had a magic wand,
right? Yeah.
And if anyone was there to listen to me, I think both, it would be great to have, all stakeholders involved, right, and be comprehensive about it. So I really do appreciate your work and helping us kind of lay down a marker of like, here's where we're at right now, and we can kind of see the pathway ahead of us. We have, a lot of areas that we can investigate.
Sure. Well, thank you. Thanks very much to Dr. Heapy and to the Corps for requesting this report. Thanks everyone for joining and listening and sharing your ideas. And I think we're almost at the top of the hour. Thanks again
for joining us today. Thank you everyone for your attendance, and hopefully you have nice weather where you are and can enjoy a nice day. Bye-bye.